To scan the hip joint, we're going to place the patient in this supine position, and then we're going to place the transducer longitudinal over the hip joint. So the alignment is with the femoral neck, and this angle between femoral shaft and femoral neck is roughly about 126 degrees. Seeking for the hip joint, then we can see the acetabulum right here. Here we can see the femoral head, and then this is the femoral neck. So let us modify the image a little bit more so that we can see it a little bit better. Yes, like this. Then here we can see the acetabulum, also with the labrum, the hip labrum right there. This is a part of the iliofemoral ligament, the joint capsule, and this ligament is running towards the femoral neck right here. And to visualize this neck, we need to heel toe to distal a little bit so that the neck is more in screen and more visible. So what we are going to observe is for any bony changes of the cortical bone right here, we're going to observe how concave this area right there is, because there could be osteophytes, there could be bony irregularities, but also signs of femoral acetabular impingement, that there is a sphericity of the humeral head and that this concavity is less. And then if we go down to over the femoral neck, then we will see underneath the hip joint capsule, also part the iliofemoral ligament, maybe a fluid, a anechoic fluid, which indicate a synovitis or maybe osteoarthritis right there. So to grade this fluid, we're going to look at the capsule. So is it more concave, so following the bone? Then it's normal, it's grade 0. If the capsule is straight with a anechoic zone underneath, it's a grade 1. Is the line a little bit higher, so more fluid underneath, that's a grade 2. And is there a convexity of the capsule, that would be a grade 3 synovitis. So looking for fluids and bony irregularity of the transition zone of femoral head to neck, and of course also in the acetabular region we can see the labrum. This is not always very easy to detect pathologies with the hip labrum, unless that there is a labral cyst, because then we see a very clear anechoic zone in the hip labrum. Of course, what we can also do is ask the patient to work with the patient to make a rotation, to see any kinematics in the hip joint, and sometimes this also influences fluid collections and also the hip labrum. So that is definitely something I would do as well, static and also dynamic imaging.